Good afternoon, and thank you for joining the ASTP ONC HTI-4 Final Rule Information Session. My name is Josh Shapiro with Capital Consulting, and I'll be assisting with the logistical support for today's session. Please ask your questions about the rule by clicking the Q&A icon at the bottom of your screen. We aim to answer as many questions as possible. If you need technical assistance, please click the chat icon at the bottom of your screen. Type your issue into the chat, and one of our techs will respond to you. Closed captioning is also available by clicking the CC icon at the bottom of your screen. And finally, please be aware that today's session is being recorded. The recording and slides will be posted in the coming days on the healthit.gov. And I will now turn this over to Dr. Thomas Keene.
Good afternoon, everyone, and thank you for joining us today. I'm Tom Keene, the Assistant Secretary for Technology Policy at HHS. Earlier in the summer, Secretary Kennedy, Administrator Oz, and Director Klump announced an initiative to address one of the greatest pain points in our healthcare system, prior authorization. Prior authorization is estimated to cost the healthcare system over $20 billion a year in physician and office staff time, costs related to delayed and denied care, and costs related to delayed payments to providers. The HTI-4 final rule, finalized by ASTP on July 31st, builds on the HTI-2 proposed rule from August of 2024. In this rule, we finalized several certification criteria through the ONC Health IT certification program. These criteria set standards for electronic prescribing, real-time prescription benefit determination, and electronic prior authorization of medical services. These policies will help to advance the administration's priority to streamline and improve the prior authorization process. Today, patients, caregivers, clinicians, and payers struggle with information exchange barriers, especially in the case of prior authorization, where a lack of adopted standards and coordination leads to administrative burdens and care delays. This rule will help reduce this burden, increase efficiency, improve care, and introduce automation to decrease redundancy and unnecessary effort. HTI-4 includes criteria for electronic health data exchange and adopts additional standards to support the exchange of clinical and administrative information with payers. ASTP is committed to advancing nationwide interoperability and delivering a system where patient data flows seamlessly across systems to lower costs and improve care for all Americans. I'd like to turn over a description of the rule to my colleague, Alex Baker.
Great. Thank you so much, Tom. And thanks to everyone for joining today. So let's go to the next slide. So just a disclaimer up front, this presentation is intended to provide a succinct overview of the rule, but for the actual text of the rule, we refer folks to the Federal Register to read the actual final rule. Next slide. So just a brief agenda for today. I'm going to go over the HTI-4 final rule at a high level, and then this is a list of the key sections of the rule that we will run through in a little bit more detail. Next slide. And one more. Okay, so I think the first thing that we want to do is just make sure folks are clear on where this rule falls in the broader ASTP ONC rulemaking strategy. So back in August 2024, last summer, we released the Health Data Technology and Interoperability proposed rule, which we called HTI-2. That proposed rule had a wide variety of proposals in the ONC Health IT certification program, touched on a variety of the criteria, took steps to update a number of the standards that are used as part of the certification criteria that are in the certification program. In addition to certification program elements, there are provisions around the trusted exchange framework and common agreement, as well as information blocking. So that was the HTI-2 rule, which was very broad, and we'll go to the next slide. The HTI-4 final rule only touches on a small subset of those proposals from the HTI-2 proposed rule. So many things in the HTI-2 proposed rule that we have not addressed in this HTI-4 final rule, and that are still proposals outstanding from the HTI-2 rule. But in HTI-4, we focused on a limited number of policies that have particular intersections with CMS, as Dr. Keene noted earlier. These are elements in the certification program and standards that we adopt for the certification program that have special links to a number of important CMS policy initiatives. And for that reason, we published this HTI-4 final rule as part of the 2026 Hospital Inpatient Prospective Payment System final rule. So a little bit of a different approach as we usually publish standalone rulemakings, and in this case, we added a rider to the hospital payment rule that is published each year by CMS, given the high degree of intersection of these final policies with different things that CMS is supporting. Oh, go back just a sec. So at a high level, the purpose of the HTI final rule has much in common with ASTP ONC's overall broad goals that we share with HHS. So we're seeking to support HHS efforts to reduce administrative burdens for clinicians, seeking to improve patients' ability to receive timely, affordable, and evidence-based care, and seeking to facilitate the exchange of electronic health information across the care continuum. And let's go to the next slide. And one more. Okay, so before we get to the prior authorization topics that Dr. Keene spotlighted, going to touch on another important provision that is part of this final rule, and that is around electronic prescribing. So the ONC Health IT certification program has included support for standards-based electronic prescribing for many years. This supports the availability of certified health IT that can enable the exchange of prescription information among prescribers, pharmacies, intermediaries, and payers. Healthcare providers can use this functionality in order to securely transmit prescription information to pharmacies and to have the pharmacy begin filling that medication right away. So what we did in the final policy in the HTI-4 final rule is to adopt a new version of the standard that has long supported standards-based electronic prescribing as part of the certification program. That is a standard developed by the National Council for Prescription Drug Programs, the SCRIPT standard. This was last updated in 2020, and we have finalized to update the criterion to align with this new version of the SCRIPT standard as part of the HTI-4 final rule. This new version of the SCRIPT standard has a number of benefits, improving extensibility and organization that can support more granular logical structuring of product and drug information, supporting advanced clinical decision support and analytics, and enhanced support for electronic prior authorization and medication history, supporting faster, more accurate, and transparent prescription workflows. And important to note that this update to the standard for electronic prescribing has been done in conjunction with updates to the Medicare Part D program and the requirements there for Part D plan sponsors and for prescribers. So in a rule that we collaborated with CMS on last year, we adopted this updated version of the standard, and the Medicare Part D program finalized to include this updated version of the standard as part of their requirements for Part D plan sponsors. Now, as part of this final rule, we have focused on the supportive elements within the certification program that are part of the broader exchange of information in order to update the standard there. Next slide. So the timeline that we have finalized in the HTI-4 final rule for the use of this updated version of the standard by health IT developers in their products for electronic prescribing includes a transition period. Up until December 31st, 2027, we finalized that health IT modules certified for electronic prescribing can continue to use either the current version of the script standard or the updated version of the standard. And then after January 1, 2028, health IT modules that are certified to the electronic prescribing criterion must be updated to the new version of the script standard as we have finalized in this final rule. A couple of other updates that we made to the electronic prescribing criterion as part of finalizing this update to the standard. We finalized a requirement to support that health IT modules certified to this criterion need to support electronic prior authorization transactions. These transactions that are part of the script standard have been optional in the program for some time based on a lot of industry feedback and interest in the past couple years. And as part of the response to this final rule, we have finalized to now require those electronic prior authorization transactions as part of what health IT developers will need to do in order to become certified to this criterion. In addition to that, we have made a number of other changes to the criterion. We'll note that we have looked at some of the other optional transactions that were supported as part of this criterion that were part of the regulation, but were not required in order to become certified. And we have removed some of those other optional transactions in order to simplify program requirements and focus on priority functionalities. Let's go to the next slide. So continuing on pharmacy, we have also finalized a new criterion in this HTI-4 final rule that focuses on real-time prescription benefit functionality. Just to talk a little bit about the benefits here, these are real-time benefit tools that empower providers and their patients to address affordability issues at the time that a product is prescribed by comparing the patient-specific cost of a product to the cost of a suitable alternative and comparing prescription costs at different pharmacies. We believe this will improve the ability for patients to get cost and coverage information in a format that all EHRs certified to the criterion would be able to consume, reducing the need to have one-off interfaces between health IT products and the different folks providing that coverage and cost information. And we're really looking to these changes as a way to satisfy the demand that patients and clinicians have for this information. And in order to take advantage of research that has shown that access to this real-time prescription benefit information can potentially increase medication adherence and reduce out-of-pocket costs. And finally, important benefits of this criterion are being able to, again, align with changes made for the Medicare Part D program. Next slide. So to go into a bit more detail about what is in the criterion that we finalized, and to note that an important additional factor in our finalization of this criterion is implementing the Consolidated Appropriations Act of 2021, which included provisions focused on both requirements in Medicare Part D as well as the Health IT certification program around real-time benefit tools. And so by finalizing this criterion, we are seeking to meet the provisions of that 2021 law. That 2021 law also included a provision around adopting a standard for real-time benefit tools that would be common between both the Medicare Part D requirements and the certification program, and that was the incorporation of the NCPDP real-time prescription benefit standard version 13, which we completed with CMS as part of that rule that I mentioned last summer, in which that standard was adopted and CMS updated requirements for Medicare Part D plan sponsors related to real-time benefit tools. So as far as the compliance date for the real-time prescription benefit certification criterion, another thing that the Consolidated Appropriations Act of 2021 said was that we needed to include real-time benefit functionality as part of the definition in statute that is the basis for what we call the base EHR definition, which defines a base set of capabilities that participants in the Promoting Interoperability programs need to have in order to participate in those programs. And so by the law updating the statutory definition that the base EHR definition is drawing from, we have made those updates to add this real-time prescription benefit criterion to the base EHR definition after January 1st, 2028. So after that date, health IT products that are seeking to meet the base EHR definition would need to address and be certified to the real-time prescription benefit functionality. Another provision of that law that we are implementing as part of this HTI-4 final rule is a requirement that those health IT modules presented to for certification to the electronic prescribing criterion must also be certified to the real-time prescription benefit criterion. So another element of that Consolidated Appropriations Act that we are implementing as part of finalizing this criterion. And again, broadly, we expect that by supporting certified health IT that meets the standard and functionality for real-time prescription benefit checks, we will allow clinicians to access patient-specific out-of-pocket costs and coverage information for prescriptions, drugs, vaccines, and Medicare Part D covered medical supplies that they are seeking to order. Next slide. And with that, I will turn things to my colleague, Jeff Smith.
All right. Thank you, Alex. All right. So I'm going to cover here a couple of aspects regarding electronic prior authorization. I know Alex had touched on a little bit as it related to electronic prescribing and Medicare Part D. This is going to be really an overview of many of the pieces that we proposed in HTI-2 related to electronic prior authorization on the clinician or the provider side of things. So as you can, as you may recall, we did propose a set of criteria for electronic prior authorization. One criterion which would have been specific to health IT used by clinicians, and one criterion we proposed would have been set for payers. What we ended up doing in HTI-2 was focusing just on the provider side, just on the health IT that is routinely considered to be certified EHRs. And we think that there are a number of benefits. Obviously, this is an area of work that has taken a lot of time, a lot of energy, and costs a lot of money, in addition to cost patients and clinicians a lot of time. So this is part of a broader HHS wide approach to electronic prior authorization, as you heard the Assistant Secretary mention earlier. And really, this is meant to address department-wide goals for interoperability as well as burden reduction. We think that these certification criteria will address some of the challenges that have significantly and negatively impacted patients and clinicians. For instance, delays experienced by the lack of information or lack of access to information, and overall, this space is tremendously complicated. And more often than not, it is very solutions-based, point-to-point interfaces, and kind of bespoke exchange pathways. So we believe that multiple criteria, and we'll go into this in a second, multiple criteria spanning each of the three main interactions involved in prior authorization as developed by HL7 through its Da Vinci project, will support the provider technology stack. We also think that this approach will help enable exchange of information in a more effective marketplace by increasing competition and providing benefits to both clinicians and patients as we try to tackle this far-reaching and widespread challenge related to prior authorization. So if you can go to the next slide, please. So in a nutshell, we have finalized three distinct certification criteria rather than a single certification criterion to support providers who are engaging in electronic prior authorization. These three criteria are based on the Fast Healthcare Interoperability, or FHIR, standard and implementation specifications, which have been developed by the Da Vinci project. Now, a lot of these, the three components here were proposed. It was just that we proposed it under a single criterion, and we heard from multiple interested parties, especially in the tech space, developers of certified EHRs and other tech companies, that having a single criterion may present challenges, and that we ought to think in ways to make the program more modular. And in specific, we ought to think about how we can make electronic prior authorization more modular, since it is not traditional that a single kind of instance of an EHR has access to all of the information that may be necessary to facilitate a prior authorization. So we took this to heart, and we finalized three separate criteria that really try to go through the entire end-to-end cycle of what a prior auth would require. So the coverage requirements discovery criterion defines a workflow to allow healthcare providers to request information from payers about coverage requirements. The next piece here is the documentation templates and rules criterion, which provides a mechanism for clinicians and users of EHRs to navigate and quickly assemble the information needed to support a prior authorization according to a payer's requirements. Last but not least, we have the prior authorization support, which is really what allows the bundle of information and to be submitted to request a prior authorization, as well as support follow-up tasks, such as checking when the status of a previously submitted request has been fulfilled. Next slide. Okay, so I think it's also important to note here that these certification requirements are intended to help facilitate the goals and help support programs across HHS. Most notably, the CMS interoperability and prior authorization final rule does require that certain payers establish APIs for prior authorization support. And they have recommended a set of implementation guides, and they actually have requirements for specific standards. And we believe that these certification criteria, along with the standards, that we have adopted will help support both the kind of pitching and the catching of this exchange. Now, obviously, the certification criteria are specific to the provider side of the exchange, but we also think that adoption of specific standards could be used by other aspects of HHS. And looking to the right side here, the promoting interoperability and for hospitals, and the MIPS promoting interoperability performance category for eligible clinicians. Obviously, there's already requirements that these hospitals and eligible clinicians engage in prior authorization as part of those programs. And we believe that this certification criteria will help facilitate not only that participation or that aspect of participation, but will help towards growing a nationwide infrastructure that is based on standards and that can scale alongside the timelines that have been articulated by this administration. Okay, next slide, please. Okay, so for those of you who were engaged in the HTI-2 proposed rule process, you'll probably recall that we established really a whole new category of certification criteria, and we referred to those as modular API criteria. And what we did, consistent really with what you've probably been seeing and hearing this entire presentation, is one of the main themes, which is kind of focusing in on specific aspects of the HTI-2 proposed rule that would be aligned with the priorities and specifically focused on facilitating prior authorization. And so that's what we've done here. Again, we had a whole suite of different what we called J criteria, and we have finalized those aspects that are going to be specifically meant to facilitate prior authorization. And again, focusing just on the provider side of things, we've got workflow triggers for decision support interventions on the client side, as well as subscriptions on the client side. And in this kind of framing, the client side is really the EHR side. So we believe that these criteria will establish kind of minimum requirements to support CDS hooks and subscriptions using FHIR, and that these capabilities will be important for prior authorization, but they will also have applicability to other use cases. So while the certification program only requires that these capabilities be demonstrated for certification program purposes for prior authorization, we do think that these are going to be really important capabilities for a whole for a wide use of different a wide array of different use cases. The CDS hooks standard, for example, provides a framework for fast decision support in provider workflows. For example, payer coverage at order sign is one of the hooks that we require. And then subscriptions enables the user to be proactively notified of an event or data update of interest. And I think it's really important to note that these are fundamental capabilities that are inherent to the FHIR standard. These are not capabilities that have been widely available and deployed prior to this, even though there are developers who have been engaged in developing and deploying these capabilities for their clients. This really will represent the first time that such capabilities are available nationwide. Okay, next slide, please. Okay, so now we're going to talk a little bit more about some of the specific implementation specifications that we have finalized as part of these criteria. So I think consistent with how the program has operated for years, really we try to think in terms of standards, because that means we're thinking in terms of scales. And we know that there has been a lot of work going back several years with a very wide number and type of input and stakeholder through the Da Vinci project. And so, as you can see, we've got about we have 3 implementation guides that are italicized in the blue box, and those do represent the standards that we are finalizing as part of the certification criteria. Now, I think one of the things that we heard during the comment process, and one of the things that we tried to address, and we will, continue to work on addressing, is this notion of having standards that are superseded by newer versions. So you'll see here that we finalized version 2.0.1 for the Da Vinci prior authorization standards. And we also know that there are newer versions available as balloted by HL7. And so one of the things that we will commit to do is leveraging existing mechanisms within the program. These include the standards version advancement process. And we'll also look to try and update these standards on a regular basis, if not on a basis that's consistent with what industry deems as important. So while we know that the standards that we finalized are a step behind what has currently been balloted, and maybe another step behind, depending on how HL7 ballots go later this year, we believe that there are mechanisms like SVAP that will enable the industry to move as rapidly as it needs to in order to use the newest available standards and still be certified using those standards. Now, I'll highlight here that we also did adopt a number of different or additional implementation guides that are part of the kind of Da Vinci suite of implementation guides. That includes the Karen implementation guide for Blue Button, the Payer Data Exchange implementation guide, which is known as PDEX implementation guide, as well as the PDEX drug formulary IG and the PDEX Plan Net implementation guide. Now, a couple of words on those. You'll notice here that the implementation guide for the PDEX implementation guide is version 2.1, whereas the others were lesser versions. And we knew that this, for background, we knew that there was a lot of work going into the PDEX IG, and we actually knew that the PDEX IG had a version that was soon to be balloted just before we proposed the rule. And so we gave notice to the public that if a new version of the PDEX IG was available, and if it was substantially addressed some substantial errors or omissions, that we would finalize the PDEX implementation IG, the newer version of that IG. And so we were able to do that. And then in terms of the drug formulary information and the Plan Net guide, I'll just note that those implementation guides are intended to be helpful to other parts of HHS that may be interested in ensuring that their stakeholder communities are using the same implementation guide. And so this does kind of represent, I think, a direction that we have been telegraphing for a while in terms of adopting standards on behalf of the Secretary of HHS, not just standards that are specific to the certification program. And this is really demonstration of that authority, as well as, I think in time, you'll see demonstration of how the authority can be used across various parts of HHS. Okay, next slide. Thank you. Okay, now last but certainly not least, we have finalized adoption of a new version of RX norm, which is part of a suite of vocabulary and terminology standards that we refer to as minimum standard code sets. This is mainly to ensure that there is a minimum bar of vocabulary of RX norm that is used for electronic prescribing and real-time prescription benefits. I think now is an important time to reiterate a couple of things when it comes to the certification program and standards adoption. And I think the minimum standard code set is a good example of this. We set bare minimums in many cases with these standards. So that does not mean a developer would not be able to use a newer version of, in this case, RX norm. It's just in terms of you have to be using at least this version. And I think if you look at the version that we adopted, many of you will recognize that that version is, somewhat dated. And so meeting that minimum version should not represent an incredible lift. But it's also just important to note that as newer versions of RxNorm comes out, there's nothing that prohibits a developer from supporting that newer version. And I think the same could be said for a lot of the standards that we've spoken about today. Nothing prohibits a developer from supporting a newer version of an implementation guide, so long as they can still support the version of the implementation guide that is in regulation. Okay, I think we'll go to the next slide. And I think that leaves us with a fair amount of time to answer some questions. I also know that there have been a number of questions that have been asked and answered in the Q&A box. So I think, Beth, are you going to be our MC for some of this?
I'm going to try. The questions have sped up in the past couple minutes. We were getting a bunch of them done, but there are still quite a few in there. There is a theme of several questions that I'm going to go ahead and answer myself, and then I will start pinging Jeff and Alex on a couple of specific questions. The biggest one that I'm seeing a theme and trend in the questions is about timelines. So I just wanted to clarify, hopefully this is helpful. There is not specifically timelines for electronic prior authorization has been asked multiple times, and then I will kick it to Jeff and Alex to talk about if there's any other timelines for any of the other criteria. But for prior authorization, as many of you know, there are CMS requirements that have established timelines for payer APIs. There are also CMS requirements for a promoting interoperability measure that is reporting on electronic prior authorization. In the ASTP ONC final rule, what we have adopted are standards that could be used by those payers and certification criteria that could be used by those providers. We have not, and by providers, I mean both clinicians, hospitals, and any other setting that may be using these tools for prior authorization. We have not finalized inclusion of the prior authorization certification criteria within the base EHR definition. And what that means is we have not established a compliance deadline by which developers of certified health IT are required to certify to the criterion and ensure that all of their customers have that criterion in order to maintain their certification and maintain that base EHR definition. What that really means is that we are making these criteria available for certification essentially as soon as possible. We are aiming to get testing and tools out as soon as possible. I don't want to speak too much for Rob Anthony and Jeff Smith, who are both on the phone here and run the certification program. But that means that developers could begin certifying as soon as possible or as soon as they are ready. But that the actual implementation timeline isn't being set in an artificial fashion. In other words, we're not saying that all tech must do by X date. Instead, we're trying to allow for that flexibility so that health IT developers can work with whoever their customers are, whether they are hospitals participating in the Promoting Interoperability program, or clinicians participating in the MIPS program, or developers who may be supporting payers that are looking to build APIs for these purposes, that they can work with them to meet the timelines that are set by those other programs. So that's what we've tried to do. So when you hear us saying immediately, what we're talking about to be immediate is the availability to start that certification process. And the reason we keep saying there isn't a compliance timeline is because we aren't setting one for developers. We're allowing them to work with their customers to prioritize their needs in a way that doesn't set an arbitrary deadline on the developers themselves. So I will pause there and just offer it up to Alex or Jeff if there are other timelines for the other criteria that you think are worth mentioning and referencing. There were some similar questions about modular APIs and sort of the whole scope. So if there's anything else you can update there, that would be helpful.
Yeah, I guess I'll jump in real quick, and then Alex, yeah, sorry, I can't see if you'd come off mute or not. I think a lot of the timeline here is exactly what Beth articulated. and we will be working with our HHS partners on, essentially kind of working on implementation and use timelines. I think again the division of labor with ONC and honestly any other aspect of, or most other aspect of HHS, we can just use CMS as a good example, is that, historically, unless we put something into the base or unless we put a timeline in a specific standard or certification criterion, we work with our partners to determine the timeline for use, right? And that timeline for use then kind of backs into the timeline for development and implementation. So that has been a fairly, I would say, consistent feature of the program for a decade now, and will continue to be so with the dynamic that we've established through HTI-4 here. I will say we got a question, thank you to Chris Barnes, around the kind of interplay between J20 and J21, as well as the G criteria that we have finalized in HTI-4. And I think if I understand the question correctly, then the answer is that a developer who certifies to a G criterion that cross-references a J criterion only needs certified to that G criterion to be considered certified to that J criterion as well. And so there's no need to kind of individually certify to both a J20 and J21 if, as a developer, you plan to certify to G31, G32, and G33. As part of the initial construct that we proposed, and I think consistent with what we finalized, we have a series, we've got a couple of J criteria that may be certified to as standalone. There may be a dynamic in the market that says, I want to develop a product that is supportive of CDS hooks, but I don't necessarily want to get involved in the game of prior authorization. I want to have a module, or I want to create a technology that has that capability of CDS hooks, in which case they would be able to certify specifically and only to that J criterion in order to then be available and promote itself as a certified product on the marketplace. But we did intend to ensure that certifying to the G criterion that cross-references a J means that that developer is essentially certified to both.
Thanks, Jeff. There are so many. I'm trying to sort through them. I appreciate everyone's patience while I try and sort your questions out here. There's a couple of questions on the interplay between NCPDP script standards, prior authorization, and the prior authorization IGs that we have. Is there anything that we can provide that helps to explain what we're trying to do with the prior auth for drugs versus the prior authorization as a whole? And I'm not sure who that question goes to.
Sorry, I was actually scrolling through questions when you were going through that. Can you ask that one more time, Beth?
Sure, sorry. So there's been a couple questions about, so the NCPDP script standard and prior authorization, which is aligned with Part D, and we adopted and Part D adopted. And then how that may have or not have an interplay with the Da Vinci prior authorization IG. And there's been a few that are like that. So I have attempted to tackle some in the Q&A, but if we can just say it out loud, it might be helpful.
Okay, yeah. And Alex, please, chime in here as you're able to. But I think that generally speaking, it's important to realize that the NCPDP script standard and what we're referencing now in the 2023-011 version, it is these are kind of a messaging standard that has specific requirements for fields and transaction types. It's not the kind of standard that FHIR is that has API endpoints. Although I'm sure there are ways you could consider transmitting the NCPDP content and transactions types via API. There's fundamental differences in what those transactions and those standards are trying to achieve. And I think the NCPDP script standard is very much aligned with the prior authorization for Medicare Part D drugs. And the Da Vinci IG is more expansive than that and attempts to develop a structure that would be capable of facilitating prior auth for the wide types of services and products outside of Part D drugs. So those are going to be different, and those are going to be different standards. But obviously, we look forward to kind of the work that will go underway within the standards development community, and hopefully facilitate improvements insofar as these distinct standards in any way have challenges working with one another. But generally speaking, I think one's very much focused on prescription drugs, and the other is focused on the wide world of prior auth outside of that.
So there are a few questions that relate to the IGs that I'm going to try and bang out really quickly for those who are curious about some of the cross-references. So some of the IGs have cross-references to each other, and we did specifically adopt some IGs that may not be specifically referenced in a certification criterion. So a quick explanation for how some of these pieces work together. If there is a reference to a specific part of an IG in one of the IGs that we did adopt for a criterion, a developer that is certifying to that criterion has to meet those must support requirements. So that would mean that if there's a piece of another IG that is referenced within one of the IGs, that piece is necessary. What we've done with the adoption of standards on their own, that is to say where we have adopted several standards that are not specifically referenced in an implementation specification, that is part of our authority to adopt specifications on behalf of HHS. So the purpose of doing so is to help, first off, put those first and foremost in the available standards that other programs might want to reference, but also to allow for alignment to those standards across various contracts, grants, cooperative agreements, other program references. So essentially what that is doing is putting those front and center for if SAMHSA or HRSA or CDC or some other part of CMS wanted to identify a standard through a grant or contract, that they wanted to make sure they were aligning with the types of standards that healthcare providers and clinicians and other entities that are already using technologies under CMS programs, for example, like some of the payers, using the same standards across those programs. So that's the purpose for that. There may be standards that are cross-referenced in an IG, but not independently adopted, and that's the reason for that. We may not have determined that it was important or appropriate to independently adopt an entire IG, but there may be a part of it that is referenced in some other piece. So that piece would be required for that certification purpose, but the entirety of the IG itself may not be the primary thing that we're pointing to at this time. We're trying to sort of balance things that we think are really going to advance interoperability with things that we think additionally may need some readiness, and really sort of work through that process piece by piece and look at each implementation specification on its own merit for that purpose. Hopefully that helps with several of the questions asking about that interplay there. And I don't know if Jeff or Alex, if you have picked one out that you want to answer directly, I will look back and see if there's any that are good for you as well.
Yeah, I can do one. I can do one that's relatively straightforward and easy, and then I can look for a couple others that I think are more kind of thematic and may take a little bit extra time to discuss. But there's a question in here around the impact of capabilities associated with J20 and J21, which would be kind of CDS hooks and subscriptions. Again, just to remind folks, how would this impact other G criteria such as G10? And I'll just note that at this time we haven't finalized the proposals that we had in HTI-2 regarding G10. So I think if you're looking beyond the end of this year, then there are no There are no requirements to update G10 other than US CDI version 3, but again, that was a a requirement that was established in HTI-1. So the current J criteria that we have finalized in J20 and J21 have no real bearing on any other J or any other G criteria other than where they're cross-referenced in G31 and G33, I believe.
And there is a question specifically that I think we can split the hair here and answer on the privacy and security framework, specifically just for the new modular J criteria. It's just it looks like there was a difference in what was finalized versus what was proposed. Can you answer that quickly, Jeff?
Finalize what was proposed for the J criteria specifically versus what was proposed? Just for the J criteria?
Yeah, for the J criteria, just for the J criteria with the, in relationship to the H criteria, privacy and security certification framework.
Oh, right. Yeah, so we did not finalize any of the related privacy and security proposals that we had in HTI-2. As it reads today, and as a result of HTI-4, we do not have the kind of wraparound privacy and security requirements for those J criteria.
Thank you, Jeff. Alex, I don't know if you had any specific tagged ones that you wanted to respond to out loud.
Just a sec, just responding to one.
All right, while you're doing that, I'll come back to you in just a second. There's a couple that I wanted to clarify a little bit as well. There are, again, several questions about the statistics about users and the statistics about the cost for the investment and the return on investment. We did include a fairly substantial regulatory impact analysis within the final rule, and it does estimate costs for the development, acknowledging that those costs would likely be passed through costs for health IT developers, and it uses several recent studies over the past 5-ish years that are exploring the cost in time, in burden, in clinician documentation hours, in administrative personnel hours, and also in patient safety incidents that have been identified in academic research about the cost of delay for prior authorization. So we've made an effort to create a fairly conservative model that does an estimate of those costs and benefits. It is included in the rule. It is way too long for me to go into detail here, but we do have that information available in the regulatory impact analysis in the final rule. If you go to the final rule page and literally type in regulatory impact analysis, it will take you to that section, and you can kind of see the estimate. We did see a fairly substantial cost savings over time. As Tom mentioned at the very beginning, we're literally talking about $20 billion of potential waste, both for healthcare providers, healthcare facilities, clinicians, documentation time, staff, and patient safety and patient experience and outcomes based on prior authorization delay. So we think there is a substantial return on investment here, but we did try and acknowledge the initial costs for development and deployment of these tools. Alex?
And Alex, while you, let's see you come on. There you
go. Just had one question, I think, following up on what we touched on a little before. Do e-prior authorization HL7 requirements include prescription drugs, or is that NCPDP? For this, It's a little bit contingent upon what you're using it for and the requirements that are set by the payer that is receiving the prior authorizations. So as part of the certification program, we're supporting functionality that enables prescribers to use health IT products for these. For prescription drugs specifically, as that is tied to the requirements for Medicare Part D, that is where we have adopted the NCPDP script standard and where the Part D program has adopted that as well. And so we've adopted that in order to support exchanges with Part D program plan sponsors, as well as other types of payers.
Okay, I've got a couple of questions here.
Great.
That I can jump in on. I think we just got
okay. You have a minute. We have 2 minutes. So go fast, and then I want to tell everyone where to find more resources.
Okay, perfect. And this is aligned with that. I think there's a question in here from Andrew Tomlinson regarding how providers can engage in ASTP ONC to further improve the electronic prior auth process. And I think the Da Vinci IG development process that HL7 has been managing now for a number of years is the right place to focus your attention. I think we are naming these standards, and oftentimes what ends up happening when we name standards is a bunch of different people start to look at the standards and go, whoa, there's some significant gaps here. We need to address those gaps. And I think a great example of that is how we finalized FHIR in the Cures Act final rule. And then people looked at it and they looked at the US core implementation guide and they were like, yeah, we need a new version of that implementation guide. And so we were able to leverage SVAP to enable developers to use the US core version 3 to meet US CDI version 1. And I would anticipate similar types of activities have to go underway, because we know that these implementation guides are not perfect, but they are so much further along than anything else out there, and they're going to scale. And quite honestly, we need individuals, we need experts, and we need different stakeholder groups to be looking at those IGs and engaging with the Da Vinci process to update those IGs and to ensure that consensus-based standards are the scalable solution to nationwide interoperability.
Thank you, Jeff. That is an excellent one to land on. And if we can go to the next set of slides, next slide. So again, healthit.gov/HTI-4. You can find the blog post there, the fact sheet, a URL to the final rule. As mentioned, there's even a piece of the final rule that actually talks about what Jeff was just talking about, as well as the regulatory impact analysis. They are all available there. We are going to put the recording for this, as well as the slides, up on that page as well. So there will continue to be resources added. Any additional sort of questions, or if we determine that we need to do a deeper dive on any topics, we will be posting those potential new events on this page as well. So this is a good site to take a look at as we continue to work together to implement these policies. And then if we can hit the last one real quick. These are our various ways that you can get a hold of us. So obviously there's, our listserv messages, our social, but the Health IT feedback form is another tool that you can use. If you want to send a message, we use a tracking system so we can see the messages that are in there and share them across all of our subject matter experts. So it's a good tool if you want to submit something to us that you really need us to take a look at or think about. That is one pathway that makes sure that we see it, we get it tracked, we get it across all of our teams, and you never have an issue with someone being out of office and your information getting buried. So that's a great tool to use. We encourage you to take a look at that and send us messages. Again, please keep the feedback coming. To Jeff's point, the HL7 process is absolutely essential for us in understanding both development needs, real-world implementation, any updates that are needed. But we also want to hear from you directly. Please don't hesitate to reach out. We are absolutely interested in hearing how implementation is going, how real-world needs need to be addressed or adjusted. And also we are in constant contact with CMS on these things. So things for them about what their policies are for healthcare settings, for clinicians, for hospitals, is a really important thing for us to hear about so that we can get this right. We think this is going to make a huge difference, and we want to make sure that we're implementing it successfully. And that really comes down to collaborating with you all. So please keep in touch, and we appreciate your attendance today.